Hello everyone, I am Hrushikesh Divyateja. I am one of the chemical pathologists working in Nottingham. I thank the Paget Association to give me this opportunity to speak today, particularly in this very historic venue. I follow cricket very much. I was here when Stuart Broad destroyed Australia one Friday morning. I was here when England raked up the world record one-day score. It's a shame that Notts Outlaw didn't win the T20, but they really played well. Now I'm going to speak about update on investigations and bone markers. And I thought as much changed in the investigations and bone markers, so I thought, okay, I will go through some cases. This would be my outline of the presentation to say what imaging techniques we use, what bone markers we use, and a bit about new Paget's guideline. I'm not sure whether all of you are aware, which was actually written under the guidance of Prof. Ralston here, and it was published in JBMR, Journal of Bone and Mineral Research. And Paget's Association actually funded that to be made open access for all the health professionals. Thank you very much for that. And in fact, you will find a link on the Paget's Association Health Professional tab. So please have a look for all the health professionals. So we have heard what Paget's disease of the bone is. It's a condition where normal cycle of the bone renewal and repair is disrupted, and characterized by rapid bone remodeling and the formation of bone that is structurally abnormal. And based on, to identify various features of this, we target our investigations. So as I was saying, has much changed. This is a patient. This is the first Paget's case I came across. I did my medical school in India. We actually didn't see any Paget's there. Whether it is completely under-recognized, I don't know. So I came to this country, this was in 2003, for all, we are called baby doctors then, the JHOs, junior house officers. I used to work for an endocrine consultant, and this was a patient referred there. And actually, I had to, those days, we didn't have Google much, and there was no smartphone. So luckily, I was carrying the Oxford Handbook of Medicine, which had some information about Paget's, and my endocrinologist made me read quite a bit about it, and that's how I remember it still. But as you can see from the referral, I actually think the GP didn't know much about what Paget's is. He just said, well, actually, ask for something else, and the radiologists have commented that there are some changes keeping with Paget's. What should I do? Now, fast forward, this is in 2009. I was registrar working with Dr. Hosking and Dr. Prinsloo here. This is another patient referred, 67-year-old who had raised ALP for 5 years. And now he's getting a bit stiff. He tells me that his father has some disease affecting his bone. In fact, his father had Paget's. There is a significant delay in referral. This is yesterday. This is a referral which I was just vetting, what we call just reviewing before we see the patient. Sorry if you can't read it. Again, a similar picture, 88-year-old, I suspected osteoarthritis, and pelvic X-ray shows that it shows Paget's. And as you can see here, it says she has raised ALP, and when I look back on the computer, she has raised ALP for 2 years. And you can just see there where I have said suggest referral to my clinic. I mean, we just need to get some message across to the general physicians that there are some investigations and there are some things which point towards where you may need a faster investigation. What do we do? Most of the imaging techniques we do are sort of confirmatory. I have been given to talk about a bit on bone markers, but bone markers are usually suggestive. We can't just make a diagnosis based on bone markers. We already heard about imaging techniques a bit, what we tend to use, and by far the common thing that is used is X-ray, and even just one X-ray, pelvic X-ray is usually picks up Pagets in about 70% of the cases. But when we say targeted X-ray involving pelvis, tibia, skull and facial bones usually help us to identify about 90 to 95% of Pagets. And we have typical appearance in the Pagets, like here, this is one of my patients. You see what we call osteosclerosis or osteolytic lesions. We also say something called cortical thickening, narrowing of the bone marrow or cortex and medulla merger. So, there are some typical features which is quite well described in Pagets, which is bit different to any other metabolic bone disease. And usually a musculoskeletal radiologist is very good at picking it up, putting it in the report, and that is usually how the referral to our system works. This will be followed by imaging techniques, something called bone scintigraphy. You already heard a bit about it. What we tend to do is, well, actually the nuclear medicine guys, we make the referral for bone scintigraphy. They inject the patient with radioisotope labeled technetium, which is linked to a bisphosphonate. Usually it's a methylene diphosphonate. And the typical features include a very homogeneous uptake, which is, as you can, oh sorry, it's very bright there, I don't know whether you can appreciate, but it's usually a very bright intake, homogeneous intake of the isotope within the affected bone. When we did the X-ray in this patient, he actually didn't have any pain in his shoulder or clavicle, and in fact it's only with the radionucleotide scan we came to know that even his clavicle, the collarbone, was affected with Pagets. This is another the bone scintigraphy scan of this patient, just showing again a typical uptake. This patient already had a deformity by then. This is mainly we do to look at what's the extent of Pagets, and the other thing which I need to mention here, this is the same patient. We ask something called quantitative bone scan, and this is again not new. In fact, Dr. Hosking here did some studies in Nottingham in 1995 about quantifying the activity. What we actually do is nuclear medicine guys do a gamma count of the activity, and they compare the active bone to the inactive bone, and I have just enlarged what they have said there. They give a ratio of activity left femur to right femur, what's the activity, and this helps us to decide whether the Pagets is active, metabolically active. We keep the record, and let's say this patient then go into remission, and then they start complaining of pain again. Depending on the bone markers, we then decide whether to rescan them, and when we rescan, we also look at the activity, compare it to the before, and try to see whether they need bisphosphonates. In terms of other investigations, CT scan or MRI, usually, yes, CT scan also gives the same information as X-ray. You can find the extent of Pagets, but it's high radiation. I don't think it gives any additional information in the diagnosis of Pagets when compared to X-ray and bone scan. We tend to use it mainly looking for complications. This is one of my patients. You can see his left, well, both the hemipelvis are affected with Pagets. Left one has already had a fracture which is fixed. He was complaining of quite severe pain in his right hip. We were not able to differentiate much with the bone scan. His bone markers were raised. He had a trial of bisphosphonate. He had a bit of relief with the pain, but he still had quite severe pain. I was slightly concerned whether he has any sarcomatous changes, and he couldn't lay still. That's why he ended up having a CT rather than MRI, although I would have preferred MRI. But reassuringly, it just confirmed that it was osteoarthritis affecting the hip, and he ended up having a hip replacement. And as one of the gentlemen was asking here, he's from Grantham, which is a town nearby, and he was initially referred to an orthopedic surgeon in Grantham who did not want to operate, and I actually asked him to refer to Nottingham, and he ended up having the surgery here. Other investigations which we do, which can be done, is something called PET scan or bone biopsy. These are again specialist investigations, usually not required. I think biopsy, there are some typical changes we see in biopsy, histological findings. Actually, nowadays it's difficult to find a histopathologist who has experience in looking at the bones. So I have not requested any bone biopsy at all so far. It has been said that it has a role in diagnosing osteosarcoma if imaging techniques are not very helpful. Sorry, I think some of these are many medical terms. I try to keep it as non-medical. I'm not presenting any too much research data, but I be appreciative that some of the things are a bit medical. I will try to make it as non-medical as possible. And also, apologies if my slide look a bit bland. It's for a purpose. I don't know how many of you know. There is something called color blindness, and about 15% of males are color blind, and I am one of them. So I am red-green color blind. So if there is anything projected with red background and green lines, I can't see it. Now, if someone, especially males, tell you that you can't understand 50 shades of gray, you know why. Anyway, and now you know why motorway signs are like this. Bone markers. I feel the role of bone markers is in hinting the clinicians to say there is some problem, and then most of the role is in monitoring. It's not about, it doesn't have a clear-cut role in the diagnosis, I feel. How do we use the bone markers? Why is it affected in Paget's? In Paget's disease of the bone, there is change in the bone formation as well as bone resorption. So we use various bone markers which are involved in bone formation and bone resorption and try to make some understanding of it. I've just mentioned some markers which are used in bone formation. This is the widely used total alkaline phosphatase. It's a marker of what we call osteoblastic or bone formation activity. Then there is something called bone specific alkaline phosphatase, which is very much related to the bone itself. Now, total ALP, I think my next slide will tell it has various origins, but bone specific alkaline phosphatase is particular to bone. We also have historically used osteocalcin, and one of the newer ones, I say new, it's been, people have been known about it for over 20 years, but we are using it more now. Something called procollagen propeptides, either P1NP or P1CP, depending on which terminal we measure. And there are markers of bone resorption, which represent bone loss activity. We used to use historically something called hydroxyproline. So when I was studying for my membership exam, the typical answer you would tell how would you diagnose is urine hydroxyproline. It's, most of the labs don't measure it now. What we tend to use is what we call collagen crosslinks. again CTX or NTX depending on which terminal, and again it depends on which lab they send to. Some measure CTX, some measure NTX. Now, alkaline phosphatase, it's done as a part of liver function test. So, majority of you as patients would have had some ALP done at some point in time. It's just that someone has to look at it and try to understand why it is raised and investigate it. It's relatively cheap, pennies. It's very reliable in detecting and monitoring, and you have heard something called polyaesthetic disease before, where it involves more bones, especially when baseline is raised. We have a reference cutoff, and sometimes the ALP reference range is quite widely distributed. Sometimes we actually need to look at what it has been in that patient before and see whether it has gone up by 30%, 50% like that. It's just for example, it ranges from 40 to 130. So, some may have a baseline of 50, it has gone up to 100, it's still within the reference range, which means it's usually missed, but for that patient it has gone up by more than 50%. There are some junior doctors there, so I thought it will be good for them to know what are the sources of ALP. We are fortunate in our lab that we do something called ALP isoenzyme, which will immediately tell us whether that ALP is coming from liver or bone. And if it is liver, then they go into gastro. If it is bone, then we need to look at what other things can cause. I think before we tend to see in our clinic, if there is no X-ray, we want to make sure we are not missing a serious thing like cancer and other things. So, we just ask them to do some basic investigation like calcium, and there is something called myeloma screen and other things before referral. But otherwise, in otherwise healthy patient who is complaining of typical pain, it's reasonable to assume that it could be related to Paget's, and in that case we then call them in, ask for particular history, especially any joints, and then they come up and say, actually my right hip has been aching for 2 years or so, but I just thought it's wear and tear, or my lower back has been aching for so and so, and I just thought it's wear and tear. So, you then get targeted X-ray and bone scintigraphy, which will help us to make the diagnosis. A bit about something called bone specific alkaline phosphatase, not widely used, and I think in majority of polyaesthetic Paget's disease it's not required, but when Paget's affects just one bone, I have found it useful in monitoring. So, especially in the disease activity, to make sure whether they have becoming metabolically active, especially when they complain of pain. Sometimes we may not see a major change in terms of activity in radioisotope scan in them, and it's useful in those cases. Similarly, same called P1NP, it's again a marker of bone formation, and it's again similar to bone specific alkaline phosphatase. We tend to use it. In our lab we don't do bone specific alkaline phosphatase, so majority of my patients get P1NP instead of bone specific alkaline phosphatase. And one of my colleague before did some studies, not published, but compared P1NP with bone specific alkaline phosphatase. They were both what we call in medical terms non-inferior, so they both give the same information. So, we tend to just stick to one marker here. The other common bone marker we tend to use in our clinic is something called CTX. In some labs they may use NTX. These are markers of bone resorption. If you have patients with osteoporosis as well, you would be or relatives with osteoporosis, you would be aware of using this CTX, it's a very good marker of bone breakdown. So in Paget's disease, it's usually elevated, or in active Paget's disease rather, it's usually elevated. And we tend to use it in, well, not in the diagnosis. Diagnosis would be based on ALP and X-ray, and we'll measure the CTX to know the activity. If the CTX is raised, then that's also another indicator for bisphosphonate treatment, and after bisphosphonates these markers come right down, which will tell us that patient has responded. Well, the first thing we'll come to know is the pain score. So patients will come back and say, actually feel quite good. I never knew that my hip is so better. I was so used to the pain that they don't see the difference, whereas after zoledronate they tend to feel the difference. The other role where I tend to find bone markers useful is you can't keep subjecting the patients for repeated X-ray or radionucleotide scan to know the activity. So most of my patients coming will know why I ask for repeat blood tests all the time. It will help us to know what's the activity, and if the ALP or bone markers are going up, then we tend to investigate with bone scintigraphy and ask for the activity ratio. I just wanted to discuss about this case where we used combination of things. This was in 2010, I think. 89-year-old who was known to have Paget's disease, and suddenly he had sudden onset of pain in his right shin bone. No history of trauma, no history of fall, and he presented to a local district general hospital. He was seen by the orthopedic surgeon, and they said, there is nothing there, and they wanted to discharge. But patient was so much in pain that, and also he was living on his own, so he was then referred to the medics to stay in the hospital, and luckily one of the doctors there contacted us, and we at that time we couldn't get an X-ray done locally, but we asked them, just put the patient in the plaster cast, and we had an X-ray done. I'm not sure whether it is projected well, but that's where the patient was pointing to the pain, so very localized pain. So we even put a marker and tried to get an X-ray done, and we couldn't see at the time, but we were pretty sure that there was something going on, and we left him in the plaster cast. And because he lives in a place called Skegness, which is quite far from here, he was not able to travel to MRI scan pretty quickly. But later we got an X-ray done. Sorry, again it's not very much projected, but what I can tell you is there is a fissure there, a crack, and that's what we call fissure fractures, which quite often happens in Paget's bone, and all we need to do is rest, and in fact in 3 months he was completely pain free and he was able to weight bear. If was not asked to non-weight bear, then there is a big risk of that becoming a full-blown fracture. And just to highlight here, his ALP did not change much during that, but we could see there was something wrong, which is CTX, which is marker of bone loss, which was quite raised compared to his baseline. So that's how we knew that there was something wrong, and with the plaster cast it actually settled quite right down. So in summary, I feel that ALP is quite sensitive and first line biochemical investigation for diagnosis. Once we know and it is of bone origin, we need confirmation by targeted X-ray or bone scintigraphy. Other markers have role in monitoring, not in diagnosis, and CT scan, MRI have role in assessing the complications. And that is adapted from the guidelines which has been published. You can find that on the Paget's Association website, and you might have also in the newsletter.
Thanks very much. Thank you. That's fantastic.